Hi, everyone. I'm Steph.
And I'm Lisa.
And together we are PD Connect. Thank you so much for joining us. Lisa's going to read a brief bio and then we'll get this party started.
Yeah, today we are thrilled to be hosting Dr. Andrea Seritan from UCSF. And Dr. Seritan is a geriatric psychiatrist and professor of clinical psychiatry and neurology at the University of California, San Francisco. She completed her residency at Baylor College of Medicine in Houston, Texas, and then followed by a geriatric psychiatry fellowship at the University of California, LA, UCLA, for, those of us that know. Prior to joining UCSF in 2015, Dr. Seritan was on the faculty at UC Davis School of Medicine, where she also served as Associate Dean for Student Wellness. Her clinical and research interests include the psychiatric manifestations of neurodegenerative diseases.
Excellent.
Thank you so much for being here.
And welcome.
And let me see
now
if I can add spotlight.
Go.
And see if that works.
Can you hear me okay?
Yes.
Great. Thank you. Thank you so much. Thank you for the introduction and thank you for having me. And wow, it's an honor to see so many people here. First test here. Let me see if I can actually share my screen and share my slides with you. Doing okay? Can you see the slides? Okay, perfect. So thank you so much. I need to tell you that I can't see you. So I don't know if Steph and Lisa, do you want people to ask their questions while I'm talking, or do you want them to keep their questions for the end?
Usually we wait till the end, and if you feel free to put the questions into the chat if you want to, and then we'll stop and do questions at the end.
Okay, perfect. So we should have plenty of time. So thank you again. It truly is my honor to be here. Thank you for inviting me, Lisa and Steph. And then also big thanks to my former chair and one of my first mentors, Bob Hales, who is here, who invited me. And I will talk a little bit about in my acknowledgements in a moment. But first of all, I have no conflicts of interest. I do have current grant funding that is unrelated to this. I did have a little bit of support from the Parkinson's Foundation and the Mount Zion Health Fund for the 2 studies that I'll tell you about. There's also someone else who's supporting my work anonymously, and thank you very much. Just wanted to let you know that these are some of my thoughts from my experience. But this does not constitute medical advice. Please talk to your doctors, your neurologists, and maybe psychiatrists or psychologists. But I'm happy to share with you some of my experience. So first of all, for my acknowledgements, thank you, Bob, for being my chair and for inviting me to speak today. Thank you for having one of the most incredible visionary styles for leadership that allowed me to grow and continue to learn and move from UC Davis to UCSF 8 years ago. I also want to thank all the team at the Movement Disorders and Neuromodulation Center. You probably know many of them. And this is us in the corner at the recent UCSF MDNC symposium. For some reason, either my image is frozen or some other image is frozen. Just PD Connect. So can anyone tell me if you can still hear me?
Yes, we can still see you and we can hear you, and your slides are doing perfectly.
Perfect. Thank you so much. I appreciate it. So, okay, what we're going to talk about today, neuropsychiatric symptoms in Parkinson's disease, and we're going to focus on anxiety, depression, and impulse control disorders. I know there's a lot more, but we're not going to have time to talk about everything. Maybe I'll answer some questions at the end. We're going to talk about management strategies, again, from my experience. And we'll also discuss two of the pilot studies for mindfulness-based cognitive therapy for anxiety and depression in people with PD. And here I want to pause and say thank you to everyone who participated in those studies. You know who you are. I see at least 5 or 6 people here. Thank you, thank you, thank you. And I'm so proud that you're here to see the results, because I don't think I've disseminated them broadly so far. Okay, so let's talk about depression first. Studies say 30 to 40% of people with Parkinson's disease experience depression. My experience, my clinical experience at the Movement Disorders and Neuromodulation Center, that's MDNC, is a little bit different. I see more people who are perhaps referred for DBS surgeries, for deep brain stimulation surgeries. I see people where the neurologists feel like they need a little bit more advice or consultation. So my practice is a little bit different. I actually, in looking at the numbers and the prevalence during people's lifetimes, almost 90% of the patients I see had or have depressive symptoms. I think it's important to differentiate depression from demoralization. Many people with PD or neurodegenerative diseases are demoralized. It's very hard, as you know, and thank you so much to PD Connect for facilitating these forums, but also for doing everything you're doing, for allowing people a forum to support each other, and for all the exercise and wise advice you're offering. That's very important to counter demoralization. Depression is a little bit different. There's a list of symptoms that we look for, and then we ask for how long, and what have you tried, and what has worked or hasn't worked. So that's a little bit more in the realm of clinical symptoms. Why does that happen? I don't know that we fully know exactly, but we do know that there are many neurotransmitters, brain chemical deficits associated with PD, and that includes dopamine, serotonin, and norepinephrine. And we also know from our psychiatric practice that when people have serotonin or dopamine deficiencies or lower levels, they may experience depression. So we kind of extrapolate these and figured out that that probably explains a lot of the neuropsychiatric symptoms that occur concurrent with the motor symptoms in PD. And one of the best ways I've noticed, I've heard people explain this, is Jill Ostrom, my division chief at UCSF, who says basically Parkinson's disease is a neuropsychiatric disease. And that's true. It's not only neurological or motor, it also includes psychiatric symptoms, as we all know. In some of our studies, as well as many of other people that have looked at the chronology of symptoms, we found that at least half of the patients have anxiety or depression. In this case, we're talking about depression, but it's true for anxiety as well, preceding the onset of motor symptoms, meaning depression may come first or anxiety may come first, and then 20 years later, you may actually develop the motor symptoms. And the reason I'm saying this is important actually for people like me, for psychiatrists, for my fellows and my residents and med students, because you may see someone in their 40s who have all of a sudden experience new depression or anxiety, and then they don't know why. But 10 or 20 years later, a little tremor appears, and then people are diagnosed, or stiffness, and people are diagnosed with PD. That is called a prodrome. So the psychiatric symptoms preceding the onset of motor symptoms is something that's one of my research interests, but also very well described by now in the literature, at least with regards to Parkinson's disease, but also with regards to other neurodegenerative diseases. That's the prodrome. I have this figure here, and I don't think I'm going to do it justice, but basically this is from the Brock studies. The Brock pair, actually, he and she studied Parkinson's disease and actually looked at brains and found that the deficits or the neurotransmitter difficulties start in the brainstem and then extend through the circuits that are connected. So those circuits are the same circuits that may cause anxiety or depression or other neuropsychiatric symptoms. And that's how I understand it, and why I think depression and anxiety are also comorbid, so highly comorbid. This slide, which I've shown, by the way, for those of us who were at the UCSF Movement Disorders Neuromodulation Center Symposium back in September, this is redundant. So I think you can maybe hit pause for the next 15 minutes. But for those of us who haven't seen this, this was very helpful to me when I saw it. This is actually from Jens Volkmann, from a paper they published, he and his group published in 2010. And these curves are actually, these U-shaped curves are actually so helpful for me to understand, and I share with my patients. So on the left-hand side, too low, either low dopamine or low stimulation, deep brain stimulation, if we're talking about patients who've had DBS. On the right-hand side, too high, too much dopamine, medication or stimulation, if we're talking about DBS. And then color-coded here, starting with the first U-shaped curve. On the low-hand side, depression, apathy, and I would say maybe anxiety, not so much compulsion. On the right-hand side, if there's too much dopamine, you may see mania or impulsivity or distractibility. And because I have the great privilege of deciding how long my appointments are in the clinic, and I do take 90 minutes to 2 hours with new patients, and then 1 hour, hopefully most of the times with my follow-up visits, I can see patients going from off, very off, and then the meds kick in, and then they may be super on in the same hour. And you probably have had these experiences when you're wearing off medications, wait a little bit, medications kick in, and then there may be dyskinesia, but also distractibility, impulsivity. And then the blue U-shaped curve here explains exactly what I just said. So bradykinesia or tremor, so slowed movements or tremor at the same time with wearing off, depression or anxiety. And then on the right-hand side, more dyskinesia when the medications kick in, or if the stimulation is too high, the DBS voltage or amplitude is too high. And again, I'm very lucky to work with an extraordinary team where I can talk to them and say, looks like the stimulation, the amplitude is a little bit high. Maybe you can modulate that or adjust that as you're working with the medications. So that's very helpful. So this diagram, which I'll show again towards the end, is very helpful for me. And I think it explains a lot of what I'm going to talk about. Moving on, what non-pharmacological, I have to thank Lisa and all of you who are featured in the photo, for this photo. How do we manage depressive symptoms? So medications and psychotherapy, as those of us, Bob included, those of us who are trained in the field know, are the best combination, right? So the best evidence is for medications alongside psychotherapy. Actually better than medications by themselves. And I should say for psychotherapy, with one exception that I'll talk about. There is one exception recently, not for people with PD, but in the general literature, where it was shown that one mindfulness-based intervention was actually as good as Lexapro, one commonly used antidepressant, and that's mindfulness-based stress reduction. I'll show you a little bit more about that in a moment. Non-pharmacological approaches, exercise, as you all do, behavioral activation. By that we mean plan activities, put activities on the calendar, maybe late morning or whenever you know that you're going to feel well motorically. Choose that time, plan things, put them on the calendar to make sure they get done. Supportive psychotherapy, meaning talking to someone, counseling, talking to someone about what's going on. Cognitive behavioral therapy, also called CBT, actually has evidence for both anxiety and depression in the general population of people with anxiety or depression, but also for PD. There is actually quite a bit of evidence that CBT works for anxiety and depressive symptoms in people with PD. Problem-solving therapy, or PST, is another modality that has evidence for depression, especially in older adults, but also younger adults. And then the mindfulness-based interventions that I'll talk about a little bit more, the second one in particular, mindfulness-based stress reduction, MBSR, and mindfulness-based cognitive therapy, MBCT. Those all have some evidence, including some that we've contributed. I'm going to say just a few words about medications. And again, this is from my experience. Maybe it's not everybody else's experience, but this is an algorithm that I follow. SSRIs, selective serotonin reuptake inhibitors, the most common class of medications currently used for depression and anxiety. PCPs can prescribe it, internists, neurologists prescribe it. Not a lot of side effects, although there are some. And people are usually tolerate them very easily, stay on them for a long time. When people take an SSRI, they're usually not referred to me. People are referred to me by the time they have tried 2 or 3 or 4 other things, and the neurologists need a little bit of help. Sertraline, I noted sertraline, also formerly called Zoloft, no longer a brand, just a generic right now. It's available widely. I like it because you can start low doses and titrate all the way to higher doses. And I always try to, by titrate, I mean increase the dose. And I always try to stop on the dose that helps control the symptoms, as opposed to keep going higher. The reason is because you can overshoot the effective dose and then expose people to side effects. So there's no reason. If 25 milligrams works for someone, that's great. If 50 milligrams works for someone, that's great. You can go all the way up to 200, but once again, try not to do that, especially the first time when I meet someone. I should have said this. There are a few good studies. Actually, there aren't a lot of randomized controlled trials of antidepressants for people with PD. There are a few, but they refer mostly to classes of antidepressants that we don't use as much these days, tricyclic antidepressants. There are a few studies. SNRIs, sisters or cousins, if you want, cousins of the SSRIs. That stands for serotonin norepinephrine reuptake inhibitors. So they're like SSRIs, but a little bit more complex, help both serotonin and norepinephrine reuptake and making them more available to the brain. And one example in this class is duloxetine, which I like to use, also called Cymbalta. You may have seen ads on TV. Pretty good also for people who have pain or peripheral neuropathy and pain symptoms. But once again, that doesn't mean that it's going to work for everyone. Please talk to your internist or your neurologist about this. There is one more that I really like, completely different class, actually dopamine norepinephrine reuptake inhibitors. So none of those, no serotonergic action, bupropion, or also called Wellbutrin. People may be familiar if you've ever tried to stop smoking. It was also called Zyban. It may also help the apathy. So I like it when people have a lot of apathy comorbid with the depression. But I should tell you that according to a recent systematic review, there was no evidence for benefit for apathy. I still find anecdotally that people have benefit. So SSRIs, SNRIs, bupropion, Wellbutrin. And then one more, which is also an excellent anxiolytic, so medication that treats anxiety and depression, but also at the lower end of the dose range, it may help appetite and sleep. So we sometimes use it in low doses just for insomnia. And then as you go higher, as you increase the dose, it starts hitting those receptors more for norepinephrine and then for serotonin, and it helps anxiety and depression. And then I'm going to move on to anxiety, keeping in mind everything that I said, including about non-pharmacological intervention and pharmacological interventions. A lot of that will apply to anxiety. For anxiety, the numbers are also, interestingly, 40 to 50% people with PD, say the papers. My practice, actually 2/3 or at least 2/3 have or had lifetime prevalence. So during their lifetime had anxiety symptoms or anxiety disorders. Again, what I said about the prodrome preceding the onset of motor symptoms in at least half of the patients, at least in our experience. And then what's interesting here is that some of these symptoms may not appear to be typically associated with anxiety. For example, people may feel head pressure or may actually experience urinary urgency or retention, like you need to go use the restroom and then you can't go. In addition to the more typical palpitations or shortness of breath. So people are used to anxiety maybe feeling fidgety or restless or can't sleep. And maybe if you've had panic attacks, you recognize this, the heart beating fast, shortness of breath. But it's a lot more than that. It's a lot more varied in my experience, in your experience, firsthand experience with anxiety symptoms. And then one thing that I learned very quickly, and I've already alluded to, the wearing off related anxiety, also called RA. Wearing off related, meaning when people are wearing off and they're also starting to have the tremor reoccur between the doses towards the end of the dose, that may be related to wearing off. You don't treat it like you treat garden variety anxiety. You treat it as I'll tell you in a moment. It's a little bit different. And how you can figure out if this is something you're experiencing or your loved one, your caregiver, your care partner, there is a diurnal pattern, meaning always approximately around the same time, 10 a.m., late morning, or 4 p.m. And then the next question I ask when I talk to my patients, if this is happening, let's say at 10 a.m., what time did you take your last dose of meds? It could be 8:30, it could be 9 o'clock. So maybe it's toward the end of the dose. And then the next dose will come around 11. So that's how you can figure it out if it's predictably almost every day around the same time and it's toward the end of the dose. That's the wearing off related anxiety. I haven't seen it anywhere else other than in people with PD. You don't see it in the general population. Actually, if I see a pattern like this in someone who doesn't have any other symptoms, motor symptoms or anything like that, I start to suspect a neurodegenerative disease. So maybe there's something else and you need to start looking for neurological symptoms. And then the last point I want to make here is, as you all very well know, in social settings or for people who are still working, when they start getting anxious, let's say in the context of work meetings, and they have more tremor or more freezing of gait that activates the anxiety. So it's like a vicious cycle. The anxiety worsens the motor symptoms, or I've seen people fall a lot more when they get anxious, maybe because of fascination, maybe because of freezing of gait, and that in turn causes anxiety. And that's, you have to interrupt this cycle somewhere, right? That can be very difficult, and actually people can get injured. Another super helpful graph to me, when I saw this, again, I understood a lot more what I'm explaining to you right now, and you're probably very familiar, the wearing off period. So this is what your day looks like. There are motor and non-motor fluctuations. This graph in particular is for motor, but I extrapolated, same for non-motor fluctuations, including anxiety or depression. Take the meds, takes a little bit, maybe like half an hour for the meds to kick in, then the symptoms are alleviated, the medication peaks, and here you can probably do a lot more, because this is the time when you feel physically, motorically well, in control, and then the symptoms start to return, and that's the wearing off period. And that's also when people may experience anxiety or depression. And I've seen even suicidal ideation, people being very despondent during this time, and then the medication kicks in, and then they feel better. So what I mentioned, I'm extrapolating wearing off related symptoms, anxiety, RAS, so wearing off related anxiety, depression, but I've also seen cognitive, feeling foggy cognitively, and then tremor and rigidity, and then they get better after the medication starts to work. And then also, I want to share something newer that I've learned, that in about 5% of cases in my experience, and I've actually looked it up and haven't found a lot of papers on this, there is also anxiety in the on, so here on top, where people are feeling good, or on with dyskinesia state. So wearing off, I would say 90 to 95%, but I'm starting to see a lot or a little bit more on related anxiety. It doesn't really have a name in the literature, so we're gonna have to come up with a name. But basically, every time there's a motor fluctuation, there can be non-motor fluctuations with the anxiety. Anxiety is the most common non-motor fluctuation. This is a very recent systematic review that showed that among people who had motor fluctuations, they also had a lot of anxiety and depressive symptom fluctuations, and you can see the numbers here. And coming back to this graph that I showed you from Dr. Volkman. So again, we have low medication, so low levodopa, so wearing off. We can add on the left-hand side anxiety, RA, that we just talked about. But then also, as I mentioned, not so common, but it exists, and I've been seeing it. And actually, neurologists my neurologists in my group are starting to refer their patients to me for this particular question, how to treat this one, the anxiety that's associated with the on or on with dyskinesia states. Okay. I mentioned, again, medications and psychotherapy, the best evidence for the treatment of anxiety. Same medications that work for depression will work for anxiety, perhaps with the exception of bupropion. And I said perhaps, it is in general believed to be a medication that's more activating and not so great for people who have a lot of anxiety. But in reality, I've seen people respond well with bupropion, even if they have anxiety, but also depression, not just anxiety. Same therapist that we talked about. And then I'm going to say this slide was supposed to have changed. I apologize. So moving on to the next slide, this is, I separated because this is so important. So please talk to your neurologist. Please don't take this from me. I am not a neurologist. I couldn't possibly advise on this, but here's what I learned. If people experience the wearing off related anxiety, so low levodopa, low dopamine levels, first of all, keeping a log, a symptom log, and putting reminders on your phone or any other way, reminders to take medications on time. This is actually the most common observation I made, which is people don't remember to take their meds on time, or they get preoccupied because they're feeling good, they're doing something, they're out in the garden, or maybe out having a walk with friends, and they forget to take their meds, they're a little bit delayed, and then they start experiencing this wearing off, both motorically and non-motorically. So taking meds on time, on the schedule, as the neurologist advised. If that doesn't work, I talk to the neurologist. The neurologists in my group, usually we collaborate very closely, and then I ask, would it be possible to space the medication, PD medication doses closer to each other? So make the interval shorter between the doses. If that's possible, that's great. But sometimes neurologists don't want to do that, or the patients don't want to do that, because that means that you're left with a big interval without meds at the end of the day, or will increase the dose inadvertently. In that case, long-acting levodopa, such as Sinemet CR or Retari, are good strategies. And again, I talked to the neurologist, I'm not prescribing those. Parcopa is there with question mark because I think it has been discontinued. Parcopa was the disintegrating tablet, which was perfect for in the middle of the doses, wearing off or rescue medication. I learned this trick from Jill Ostrom in my division, Crush Sinemet. She actually doesn't use Parcopa, but uses the new formulation called DV or Divy. I don't know how to read it, or Crush Sinemet, meaning chewing the Sinemet. And that will be in the moment for the wearing off related anxiety. And then there are all the other strategies that your neurologist will know. If those don't work, or after those have been tried, then we can do the SSRIs, SNRIs, and everything else that we talked about. And really, if we have to, there's one more line of medication which we do not prefer, but we might need to use, and that's benzodiazepines. Things like lorazepam or clonazepam. Not the first line, but you may get to that if you're experiencing crushing panic attacks or anxiety symptoms. For the on anxiety, again, the neurologist does this, not me, and please don't do it, or please don't try it on your own. I'm still working with several neurologists in my group to try to understand this and figure out what the best strategy is, but longer acting levodopa, so a smoother release. And that actually Retari does that, a smoother release, because you want to prevent the peaks, right? So in this case, it's the peak of dopamine. And I should say it's not just anxiety. Again, I've seen impulsivity, I've seen hyperexcitability, I've seen elevated mood with this on, and I've also seen some very difficult mood fluctuations when people get very upset, cry, and then it ends. And it's like 20 minutes. So clearly it's related to the medications. This is not something that my patient was doing at baseline. But then she got put on a lot of very high doses of levodopa. And then extenders, by extenders, I mean the newer medications that, again, I'm learning from Dr. Ostrom and the neurologists in my group, things like opicapone and other things. Will they have a role in here? I don't know yet. But certainly, if there's anything that can be done to prevent the peaks in levodopa, that's it. And remembering that different people have different absorption curves. You probably know this. So some people may absorb medications immediately and very well. Other people don't. Depends on what you've eaten and when. So this is complicated, and that's why we're talking. I'm not going to pause here. I'm going to move on to the impulse control disorders in 2-3 slides, and then tell you a little bit about our studies of MBCT. By the way, I'm not used to talking without a break. I'm used to taking questions in between. So I hope I will remember, or I will see all the questions at the end in the chat. Impulse control disorders, this is also interesting, difficult for patients and families. 14% of the people with PD as a result of dopamine agonist. So this is a side effect of the dopamine agonist or levodopa therapy. I've also seen people who had some difficulties with this before they ever had PD or before they were ever taking levodopa or dopamine agonist. But most people I see are either taking levodopa or dopamine agonists. A very well known, or I should say well known side effect of dopamine agonists. And if you don't, please pay attention to this because this is very important. Gambling, and the reason I said in parentheses in the DSM-5, this actually made it in the diagnostic manual for psychiatrists, gambling, but none of the others are. So they're hard to diagnose for us if you're really trying to use the psychiatric diagnosis. Compulsive buying, compulsive sexual behavior, internet use, I've seen scratchers, playing lottery tickets, overeating, substance use, punting, which means purposeless stereotype behavior, arranging things and then rearranging and arranging again, or collecting. Those are some examples. Risk factors: younger age, male, young onset, Parkinson's disease, unmarried, history of cigarette smoking or alcohol use, or family history of gambling or substance use, and then personality traits. I would say personality traits I always take with a grain of salt because personality is very difficult to evaluate or to understand fully. And it's very hard to go retroactively and understand this when you have someone who's already suffering, experiencing ICD, impulse control disorder. Okay, what to do about this? There are some strategies, non-perfect. Reduce or discontinue the dopamine agonists or levodopa as tolerated, meaning you can't stop them. I actually have a couple of patients right now where we're struggling to reduce the dose because the motor symptoms will stop you, right? Dopamine agonists first, levodopa last. And then if there are any kind of rescue medications, you may be familiar with Apoquin, things like this, apomorphine, so it's the injectable one, or the inhaled levodopa, those go first. Those are the most dangerous because they have instantaneous absorption and effect. Behavioral strategies, you can place filters on electronic devices. I've had people put filters on one, but not the other. Explain to me they really needed the phone for some things. It doesn't work if it's not a strategy, a uniformly applied strategy. Some people ask their significant others to only give them cash. Some people don't do well with cash because they'll go spend it to the casino. But some people, it works. No debit or credit cards. CBT, cognitive behavioral therapy, has evidence. Couples therapy, as you can imagine, this is very difficult for the spouses, for the care partners. And then with regards to medications, citalopram or escitalopram, that's Alexa or Lexapro. I've had some success. My patients who've struggled hard with this have had some success. Maybe other antidepressants, anxiolytic, no evidence so far. Now, Trexone is something that we use for people who have alcohol use difficulties or opioid use. And then this may be okay for ICD. And then the last line there, STN-DBS, subthalamic nucleus DBS. Is it possible? Maybe. Should it be the first line? No. Right, the surgery, an invasive procedure should never be the first line. But sometimes people do get DBS and that improves ICD symptoms. I should say STN, DBS, STN in particular, rarely can actually worsen impulsivity. So that's why question mark. And then again, working if I am managing, if I'm involved in managing these kinds of symptoms, I work very closely with our neurology team and the programmer, the person who programs the DBS, because that's where we have a few more strategies: gentler slope, slow, 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 low amplitude, and slow titration. So there are a few strategies there that I've learned through the years, and obviously working with an incredible team at UCSF. Okay, moving on. Let's see how we're doing. We're doing okay, Lisa, on time. 5-10 more minutes, and then half an hour for questions.
Yeah, great. Thank you so much. You're doing great.
Okay, perfect. Thank you so much. So I wanted to talk. So Lisa asked me to talk a little bit about non-pharmacological treatments. Obviously, it's not just medications, and I completely agree with Lisa's point and with everything you're doing with PD Connect. Non-pharmacological strategies have no side effects, except if you, I don't know, if you are too eager with your exercise regimen. But therapy has no side effects unless you have a terrible therapist. And that hasn't happened too much in my experience. So mindfulness-based cognitive therapy, I promised I would talk about this. Mindfulness-based cognitive therapy. What is it? It's a mindfulness-based intervention, meaning meditation and a few other strategies and cognitive techniques. It actually has evidence, has been shown to prevent the relapse of recurrent depression, was actually intentionally designed for people who had experienced multiple episodes of depression and to prevent relapse and further episodes of major depressive disorder, as well as anxiety symptoms, improved anxiety. It is usually delivered in an 8-week series. So you have to go weekly, either in person. We did it in person, we did it in Zoom, arrived at a 90-minute group length, session length, based on our participants' feedback, and then independent daily practice, meaning you're in the group, you receive support from your peers in the group, but then you have to go home and do your own daily practice. And for the study, we actually logged it to keep people accountable. You don't have to do that, but for the studies, I should say. We adapted the traditional MBCT protocol. I have to thank my mentor and incredible colleague, Stuart Eisendrath. You may know, some of you may know him. He's emeritus professor from UCSF. He gave me the MBCT protocol that he had developed, and I adapted that with his help. Meaning we took out some exercises, we did yoga from the chair as opposed to yoga from the mat on the floor and things like this. And then a further adaptation, COVID pandemic hit, and then we had to finish our first study in person, made it online, and then the second study was completely online. We had, as you can see, we had IRB approval and registered on the clinicaltrial.gov database. And the two studies were, the first one was the fall of 2019 through March 2020. And again, I see some people here, and my gratitude to those of you who stuck with it and completed it. That was because it was started in person, was limited to people from the Bay Area. However, for the second one, I was fortunate to get more funding through the Mount Zion Health Fund. And the second one was during the pandemic, was completely virtual, allowing people with PD from across the US to participate, as well as the caregivers. I really wanted to do something to include the caregivers. So this one actually worked well to have some caregivers. The data I'll present today only has the PD, people with PD, doesn't have the caregivers, but there were a few. People had, so obviously we had inclusion and exclusion criteria. People had to have PD or Parkinson's diagnosed by a neurologist or be a caregiver of a person with PD. MoCA stands for the Montreal Cognitive Assessment, which is a test of cognitive functioning, and the maximum here is 30. So it was okay for people with mild cognitive difficulties to enter the study, but not so helpful for people with major cognitive deficits. And then the GAD is generalized anxiety depression, is actually a scale of anxiety symptom severity, and the PHQ-9 patient health questionnaire is a measure of depressive symptom severity. And if you're familiar with the scores, the GAD, the maximum is 21, and the PHQ, the maximum is 27. So this is actually in the moderate to severe range. We actually included people up to the last, not the last, but the highest category of scores, which was severe. If people had severe anxiety or depressive symptoms, active suicidal ideation, severe psychosis, or heavy alcohol or drug use, a little bit of marijuana was okay. Occasional wine drinking was okay, but heavy was not okay. We gave them other resources, but we couldn't include them in our study. I just wanted to show you here, in case some of you were screened for the study or pre-screened and couldn't participate for whatever reason, either to mild symptoms or the cognitive status didn't quite fit. We pre-screened, and thank you to Lisa and Steph for advertising. I think you advertised through your newsletter. So we actually pre-screened 3 times more people than the people that ended up participating in the study. In the end, we had, I believe, 13 people in one group, in one study, and 15 people in the other. So a lot of work. Many thanks to the people who helped me pre-screen, Sarah Wange and Prarthana Prakash. I'm not going to give you here the participant demographics. I have them. If you have any questions, I have them here. The table was too big for the slide, but I just want to share with you, not only were people, people who lived next to UCSF clinic able to participate with their caregivers, but also in the second study, the one that was online only, we had people from the East Coast, from Colorado, from the Midwest. I was so grateful that it worked to allow more people access to the intervention that currently doesn't. I don't think it exists in the mainstream. So the MBCT, and then you can see here in the table on the left-hand side how many people completed, but also how many people had a GAD score higher than 5 and a PHQ score higher than 5. And the reason I'm showing this is because if people had minimal, so 0 to 4, minimal symptoms, we excluded them in the secondary analysis, in the analysis that I'll show you in a moment. So what did we find? It worked. It worked. There was a significant reduction in both symptoms of anxiety for people who had anxiety symptoms more than 5, as I showed you, pre-MBCT, and also significant reduction in the depressive scores for the people with pre-MBCT depressive symptoms, again, higher than 5. I will say that the groups overlapped, meaning that just as I showed you before, a lot of people who had anxiety also had depression. So 20 of the 22 people with depressive symptoms also had anxiety symptoms. So if you ask me, I can't tell you one drove the other. So did the anxiety improve and the scores improved for depression or the other way? I can't tell you. And then the other thing I should note here, you can see the difference in terms of the number of points. So 2 points on average for the anxiety measure and almost 4 points on average. So for the group, for the depressive measure. But just to point out that in general, in the literature, a 5-point difference is considered clinically relevant. So while it was statistically significant, it may not have been clinically irrelevant, but we were happy to see this. And again, thank you for participating to those of us who are here. The group attendance, people made it to most of the sessions, as you can see in study 2, which was the one online. People made most of the sessions, 7 or 8. Very nice comments and feedback, and I have a lot more. I also have data on participant satisfaction, which was pretty high. And once again, thank you for spending the time, for doing your homework, your independent practice, and for helping all the other people in the group and the care partners. And so in summary, we think that MBCT is feasible and actually works virtually, increasing access for people throughout. If I get more funding, I do want to do more studies, larger studies, and ideally randomized controls. So because there's no control group, I can't tell you for sure that it was effective. So as my statistician, Dr. Yosef, says, always cautions me, says you can only say it may be effective, or there's preliminary evidence for improving anxiety and depressive symptoms in people with PD. If anyone here is a care partner who participated, the numbers were too low for the care partners, but the individual measures and the individual scores improved for each one of the care partners that participated in study 2. And I'm going to stop here and see what questions you might have. And I'm going to stop sharing so I can see you all. Thank you. Thank you all. I hope I haven't put you to sleep.
Thank you. Not at all.
We do.
Oh, there was a question that just
is weird,
disappeared.
yeah.
Okay.
We had a question in the chat. But anyways, yeah, if anybody has a question, if you want to raise your hand, or we can help unmute you and we can take some questions.
There was a question in the chat about AI. Do you want to type that, or was that, I feel like that was.
Can AI type it for you? I didn't see it. It disappeared. I don't know what happened.
Yeah,
it was there. So I don't, maybe that person left or got kicked off. I don't think that works like that. But anyway, if you're still here, I thought that was, I don't want to put anyone on the spot, but I thought that was Lori who asked that question. She may not be here anymore. Okay. All right. Any other questions? Yes. Denise.
I was wondering if I was part of the study, and
Hi, Denise.
is still very beneficial. So thank you. I was wondering if there is any difference in by gender in the oncoming symptoms, because when I look back, I never had anxiety until like 10 years before. And it just kind of hit me. And I was wondering, and they chalk it up to like menopause, right? So, I was wondering if now, with it being a little bit more like everybody is getting PD, it feels like, if there is more of a way to make a proactive, or a diagnosis, if it's different by gender.
I love the question. Thank you so much, Denise, and thank you for participating in the study.
Thank you.
I actually think we should look more into that. I so appreciate it. So I have the demographics in our study. They're about half and half. Women and men, and then in the second study there were more men, about 2/3 men and 1/3 women. And actually, those of you who were in the second study may remember I really made an effort to recruit more women, because I felt there were a lot of men. It's a great question, and something that is actually on my desk to read. In the stack of papers of articles that I collect to read, there may be some evidence for more non-motor fluctuations in women, but I am saying this, please take it with a grain of salt, because I haven't actually carefully looked at that. I can tell you that I was talking to my colleagues, Dr. Ostrom and the neurologist, recently in a group meeting and I asked, has anyone else seen this? More non-motor, more anxiety, non-motor fluctuations in women, and harder to treat. It was my experience. It has been my clinical experience. And the neurologists, some of them said yes, but I can't tell you that there's a lot of evidence. I do think that there is clearly a correlation with, you know, hormonal states for women. And I also think, Denise, thank you so much for pointing out that sometimes people chalk it up to, oh, it's perimenopause, oh, it's okay if you have these symptoms, let's not pay attention. And so I think it behooves us to study this further. I'm gonna go back, you know what, I'm gonna go back and ask my statistician and see if there's any difference in the data we have. It's a great question. Thank you.
I have a question.
Please.
How are you, Dr. Seritan?
Hi. Is this Susanna? I can't.
No, this is
Irene?
Janet.
Oh my gosh. Hi, Janet. Hi. I can't see. I have to tell you, you're very small on my screen. Let me see if I can do this.
Well, that's okay.
Okay. I see everyone now.
I'm wondering, I don't know what akinesia is. Akinesia, and what is dyskinesia related to medication?
Oh my gosh, Janet, this is the best question. Well, the best question so far, and besides Denise's question, that was also the best question. But I mean the best question in a clinical visit, because I struggle with this all the time. I usually ask my patients to, if they can, to videotape and show it to their neurologist, because I can't tell you, sometimes I think I'm watching someone in front of me in Zoom and I say, oh, that looks like dyskinesia. And then the neurologist says, oh, that actually was dystonia, was something else. So to answer your question, what akinesia means, no movement, no movement.
Oh, okay.
Bradykinesia, less movement, not a lot of movement. And dyskinesia, the swaying movements that you sometimes see when people have too much levodopa. That being said, so when the levodopa kicks in, but that can be very subtle. It can be a toe, it can be a finger. That being said, I have seen also something that is called dystonic dyskinesia. It is dyskinesia, it's associated with peak dose, and it's dystonic, which I usually see with wearing off. So it's complicated. As I'm speaking, I realize that I have to lower my blinds because the sun now reflects in the window across from me, and I will be right back in 10 seconds, 20 seconds.
Thank you.
Did we sing while she's gone?
Well, I don't know about that stuff.
Okay. Good.
You know, since we do have some people that were in the study, it would be great to hear from some of you about what your experience was, if you don't mind sharing. If anybody wants to share their experience that was in that mindfulness-based stress reduction study.
Well, mindfulness is life-altering. You, as opposed to just going through the motions of life, it puts a meaning to your life.
And had you ever done it before? Was it hard to learn or easy to learn? And
I had never done it before, and it was difficult because I'm not used to sitting still.
Good. And then have you continued the practice or tried to continue the practice?
Yes, I try to continue the practice. It becomes habitual.
Wonderful. Yes, Denise.
Hi, Janet. I did it twice because I'm a little slow on the uptake, and mindfulness was something I never really heard of until I participated in this study. So it was a big change of thought process for me. And so I think it totally turned my depression into something different. Like I kind of got off of the resisting having Parkinson's, and it definitely changed my point of view and makes it easier for me to deal with it. I'm just so grateful for having had the opportunity to participate twice, because I think I really needed the second. It like kicked in on the last session. I got it. So I still do it, and I feel better today than I did 3 years ago. Yeah, I feel like some days I don't feel like I have Parkinson's, but I know better. So yeah, it was definitely life-altering for me as well.
That's amazing.
Wonderful. Yeah, we love that. And, it sounds like you're describing the principles of neuroplasticity, that this new practice that you did, we talk a lot about this in our exercise classes, but it sounds like that's what was maybe happening for you as well. And it just took a little bit more time, especially in that second round, to make that happen. And we really love the outcome that you experienced. Great job.
Yeah.
Jim?
It's like believing in the process, right? Because I wasn't getting it. So I just believed in the process.
All right, I'm going to add us on here. Oh, there we are.
There you are.
Jim Nevin, you had a hand up.
And then
Well, yes, I was hoping Dr. Seritan or one of the people that participated in the study would tell us the difference between mindfulness and meditation.
It's a great question. And thank you for the testimonials. Thank you so much, Janet and Denise. Almost same thing. I think mindfulness is another way of being present and experiencing, if you want, life. Being in the present and trying to focus on that and on your experiences in the moment. And meditation is one strategy to achieve that, but it doesn't have to be. For example, if I can go back to Janet and an example that will always remain with me, mindful walking, going on walks and paying attention to things that you see around you. And then Janet would do this. Do you want to tell them?
I'm afraid of what you're going to say. Okay, no, you go. Well, I would look for colors. For example, one day I'd look for all the yellows that I would see. And then another day I would listen to sounds and just what different sounds. It's amazing how noisy the world is when you really listen to it. And I would use my senses when I would walk. Is that what you were referring to?
That's exactly it, the yellow, yes.
I thought you were going to mention the homework.
I will have to refresh my memory. I don't remember that part.
Well, you said we had homework to do, and I said that was punitive. It wasn't.
You had homework, yes.
It was exercise.
That's true. I also want to credit Denise and everyone. So I do see the names here. You know who you are. It is because of you supporting each other. And, the outcome is actually dependent on the people in the group. It's not just the instructor, so to speak. So it's thanks to all of you and the care partners. And the one study where we had the care partners, like I said, I really, really wanted to do something. The care partners always come bring the patients bring the people with PD and then remain at the door, right? So I really wanted them to be in or not out. And it was very helpful for them too, to see, to hear from other people and to feel supported. So I think there was a lot of benefit. But again, do I have enough data to say, I know for sure it works and this is what we all should do? Not at this moment. If anyone is looking for MBSR, mindfulness-based stress reduction, so is the other one, is like the mother, and the MBCT is the offspring, newer version. MBSR is being offered in 8-week sessions plus one day, like a half day or day silent retreat at the Osher Center at UCSF. It's not free. It's about $300 or $400, and I can send Lisa the link. And they usually have a wait list. The reason I don't greatly endorse that is because their sessions are 2.5 hours long, which I actually don't think is okay for people with PD. So that's why we shortened hours to 60 minutes and then to 90 minutes, and we took the feedback from study 1 participants, and they ended up with 90 minutes. You all thought it was better because you had some more time to talk to each other. But yeah, I can send the link for MBSR. MBCT, I don't know where it's currently being offered. Hopefully we'll have some more. Did I answer, Jim, did we answer your question?
If that's to me, yes, it did. Thank you.
Thank you.
Elena, did you have a question?
Yes, I was going to ask about stress. Because stress, when you have PD and you're living your life, the way you deal with things is that you normally dealt with them before you had PD is different. So having PD and dealing with certain issues in your life can cause stress, can be stressful. And so I was and that can cause a lot, that could be related to anxiety, right? Stress could be, and so I was wondering that and I CBT is wonderful. It's highly used, as you pointed out. So I was wondering, how about if taking the CBT stress release group classes would be just as relevant as taking the mindfulness. The difference between the two. You were kind of talking about that.
Yeah, great question. Great question. I would say, thank you so much for that question, Elena. I would say any kind of non-pharmacological, any kind of therapy, whatever is available, if it's CBT is great. If it's mindfulness-based stress reduction is great. I think and you're absolutely right, as you pointed out, stress can actually worsen the symptoms also in the moment. Like if there's time pressure, you're, let's say, in a restaurant, you're trying to get out quickly, more motor symptoms may occur. I've seen people fall, but then also stress in general, living with a neurodegenerative disease and having to plan every day. You're absolutely right. So anything that we can do to mitigate that stress and the impact of that stress, I vote for that. Whether it's CBT or exercise, PD Connect, walking. Yes, I see Lisa. Yes. Go ahead, Lisa. Did you want to add?
No. We were just talking about, yes,
we were just moving around like exercise.
Excited,
yeah. Yeah, absolutely. And I think, a barrier for, we haven't really talked about availability of those services in the community. So one barrier right now, especially the post-pandemic world, hoping is the post-pandemic world, is the fact that we've all been incredibly busy in mental health, both psychiatrists and psychologists and therapists. So it's kind of hard to find people, but it is helpful that those, either one of the interventions I talked about, they're short, brief, 6 to 8 weeks, and then there's space for someone else to see the therapist. So absolutely. Thank you so much. Actually, I don't want to put anyone on the spot, but I do see one of the fantastic therapists who is one of my favorite therapists here. I don't know if you want to say hi.
No, I meant to unmute. Thank you, Dr. Seritan. I'm Chloe Martin, and Dr. Seritan and I have worked together for many years, and I'm very glad to be here. Thank you.
Thank you, Chloe, for everything you do. It's so important for me to have therapists I can refer to and rely, and then can say, you know, they have experience with PD, but the people who are excellent, like Chloe, do tend to fill very quickly, and anything you can do to help. That's why sometimes group interventions, you know, are okay, because there isn't enough space for people to be seen individually. But I don't know, Chloe, since you're here, do you want to say anything more about mindfulness? Because you do have a lot of experience with mindfulness, as well as including spirituality, which I think is an aspect we didn't discuss.
Yeah, thank you. Let me see. Oh gosh, am I unmuted? Okay. Yeah. So, I would say that the good thing about mindfulness is that there are a lot of resources that are available through apps, and of course through books, and even through, you know, live offerings. For example, in our community, we're lucky to have Rick Hansen, who's a meditation teacher. He offers a meditation group every single Wednesday night that you can access online. I'm sure you know about some of the apps that help people with meditation. Some of them are Headspace, Calm, 10% Happier, and then there's one that I've been using, and sometimes I actually work with clients that's specifically working with mindfulness and anxiety. There's a book and a related app, and it's called Unwinding Anxiety by Dr. Judd Brewer. And the app is a program that takes you through, I think, 30 or 40 short videos that you watch once per day. And then there's all this additional content that includes daily reminders that help you touch into, you know, what's going on, and they're sort of reminders to be mindful. And then there are other, like body scan meditations and all kinds of tools. There is a subscription price to that, but it's actually just a really robust program. They even include an online message board where people can be communicating with each other, and a weekly Zoom meeting like this one, where there are the professionals kind of guiding people through answering questions, and there's a support component as well. So I just wanted to offer those. One other thing I'll put in the chat, I don't know if this is appropriate or not, but I'm based in Marin County, and something that I'm trying to do is to offer another social offering for people, just to address the isolation and loneliness. And I'm going to be offering, I started this last month in November, monthly events that are just for people to come together to have fun and to connect through conversation, guided conversation. My events are called Come Together, and the next one is going to be Come Together for Cookies, Cocoa, and Conversation on December 16th from 2 to 4, and it'll be in San Rafael. I can put the details in the chat. And yeah, just trying to build community, and we eventually will be building up. Last month we did a Beatles sing-along party. We're going to be building up to dancing. I know there's some dancers in this group, so there's a couple of things, Dr. Seritan, and thank you so much to PD Connect for everything you've done.
Thank you for sharing that.
Yeah.
We were, I don't know if you saw us, but we were, clapping as we were muted and throwing our hands in the air because we love stuff like this. So we know how important that social health is, and thank you for sharing.
And we are in Marin. So,
yes.
And this is all, I'm offering all of this for free. And if people need help with transportation, you can contact me, and I can help connect you with that as well.
Great.
Thank you. Thank you so much, Dr. Martin. So super helpful, and especially the cookies idea. I think that's a great idea. And the dancing. Any other question, anything else we can help with? I also appreciate the group, you sharing your insights with each other. I think that's a big part of this.
Last question, Jim.
Well, I guess I could do it quickly. I suspect there's a number of us with Parkinson's that don't realize how much we actually suffer from anxiety because it's contrary to our nature, or at least our views of ourselves. And I find my wife, who's also my caregiver and a wonderful human being, is very helpful to me if I listen to point out the things that make me anxious. Mm-hmm. So she'll tell me, and over a period of time, I'm starting to learn that what the vision of me isn't quite accurate, because she's telling me when it is I'm responding to the stress of the stuff that's going on with my Parkinson's. So I just think, I suspect you run into that in your studies and your tests. And somehow I think we need to figure out methods of being able to both give those types of information and receive them and accept them.
Mm-hmm, mm-hmm. I very much appreciate that point. And I'll say that goes in general, right? Not just PD. And I see some spouses here in the group nodding as you were talking. Isn't that important for all of us? But I think what you said, Jim, it goes back a little bit to what I said in the beginning. Parkinson's disease, that's what we're focusing on today, is a neuropsychiatric disease. So it's anxiety is part of it. So it's not a character flaw or something someone is doing wrong or forgets to do the right things. It is part of the plight of PD. And I think paying attention to it and knowing the triggers, like in the example you were giving, Jim, with people, significant others or friends or family, telling us, what is it that's a trigger, and maybe trying to avoid that and work around that and have strategies for that. Just like you have more strategies for travel around the holidays, for example, or for packing. I think it also helps to be in groups like this where people share their own strategies and, advice, including advice I've given may not be applicable to everyone, but some may apply and others may not. I really do appreciate everyone's time. And I want to once again thank Lisa and Steph, but also Bob Hales. And in particular, Bob, for your mentorship and leadership and for what you built together here. So thank you so much for having me. I'm honored. And I hope I can answer more questions if they come up.
Thank you so much. We really appreciate this. This was wonderful. You're amazing. And we will forward any other questions to you, and we couldn't agree more. Thank you to Bob.
Appreciate you so much.
Thank you to everybody here. So we always say, by the way, for those of you who don't know us, that's Lisa and I'm Steph, and together we're PD Connect. We teach exercise and education for people with Parkinson's, and we run support groups and informational guest speakers as we are here today.
Care
and
partner support groups.
all of those wonderful things. And we couldn't be more excited about coming together for cookies. So things like that are amazing.
I
And
want to ask a question. We're not going to answer it today, but
yes,
something to think about, because
yes,
I do wonder, we talk a lot about lifestyle change, any kind of dietary impacts to depression and anxiety, but not for today.
but not for
We'll have
today.
to wait
That's
another
to be
time for that.
continued. But we appreciate you all for being here. And again, we wouldn't be here without you. So thank you so much. Thank you for your time. We definitely took you
All of you.
over,
Thank
and
you
we
so much.
appreciate you. Thank you. Have a wonderful afternoon or evening, depending on where you are. And we'll see you on the flip side. Thanks so
right.
much.
Thanks
Thank
again.
you all.
Take care.
Thanks for having me.
Thank
Bye.
Thank you.